Welcome back to Medinare. In this video, let's continue to discuss about case history in orthodontics. In the previous video, we discussed about extraoral examination. In that, we saw shape of head, facial form, facial symmetry, facial divergence, and facial profile. Now let's move on to facial proportions. Facial proportions are assessed in two planes, which are vertical plane and transverse plane. Let's see how it is divided in vertical plane. The face can be divided into 1/3 by using 4 horizontal planes. These 4 horizontal planes pass at the level of hairline, supraorbital ridge, base of the nose, and inferior border of chin. A well-proportioned face has all these 3 vertical thirds in equal proportion. For a face to be harmonious, the height of the forehead, which is from hairline to glabella, should be as long as the mid-third, which is from glabella to subnasal, and the lower third, which is from subnasal to menton. Within the lower face, the upper lip occupies the 1/3 of the distance, while the chin occupies the rest of the space. In a transverse plane, face is divided sagittally into 5 equal parts or 5 equal fifths. Each of the segments should be equal in size to the width of one eye. The 5 fifths are the central fifth of the face, the 2 medial fifths which are present adjacent to the central fifth, and the 2 lateral fifths or outer fifths of the face. The central segment is between 2 vertical lines that pass through inner canthi of the eyes. The medial fifth represents the width of the eye, and the outer fifth of the face is measured from the base of the ear to helix of the ear. In an ideal face, the distance that separates the 2 eyes should be equal to the width of eye. The interpupillary distance should be equal to the width of mouth. Now let's see what is poor man's cephalometric analysis. The examination of facial profile, facial divergence, incisor protrusion, and clinical FMA, which is Frankfurt mandibular plane angle, constitutes the facial profile analysis. This is also known as poor man's cephalometric analysis. Now let's move on to assessment of smile. People are very conscious about the way they look, right? Smile is one of the major reasons for many patients to seek orthodontic treatment. It determines aesthetics at the end of the treatment. There are 5 types of smile according to Janssen EK. Type 1 is maxillary only. Type 2 is maxillary and over 3 mm gingiva. Type 3 is mandibular only. Type 4 is maxillary and mandibular. And type 5 is neither maxillary nor mandible. And when it comes to assessment of a smile, we need to check for these 5 things, which are amount of incisor display, amount of gingival display, levels of gingival margin, presence of buccal corridor, and the smile arc. The amount of incisor exposure at rest is a crucial aesthetic parameter because the sign of aging decreases by exposure of maxillary incisors. Generally, males have less incisor exposure when compared to females. And males show more of a mandibular incisor exposure. We need to record the amount of incisor exposure at rest when the patient is speaking and smiling. According to Wig and Brundle, tooth exposure at rest is 1.91 mm in males and 3.40 mm in females. In normal cases, maxillary incisal edges at rest position and smiling should be 2 mm. Now let's see what are the causes for variation in incisor display. The incisor display becomes inadequate at rest if the patient has long philtrum height, flared maxillary incisors, inadequate curtain on smile, short clinical crown height, or vertical maxillary deficiency. The amount of incisor display becomes excessive if the patient have short philtrum, excessive overjet, or vertical maxillary excess. The incisor display becomes inadequate on smile due to limited smile area, flared maxillary incisors, inadequate curtain on smile, long philtrum height, and vertical maxillary deficiency. Now let's move on to amount of gingival display. A certain amount of gingival display is considered as normal. In normal individuals, gingiva is not seen while speaking or smiling. In excessive vertical development of maxilla, gingiva is predominantly seen while speaking or smiling. This is considered as gummy smile and unaesthetic. The amount of gingival display should also be measured and recorded. Generally, females show more teeth and gingiva than male. Now let's see the types of gummy smile and their causes. The first type is dentogingival gummy smile. which is seen when there is altered passive eruption of teeth. Muscular gummy smile. It is seen when there is hyperactivity of upper lip muscles. Dentoalveolar gummy smile. It is seen when there is excessive vertical descent. And mixed gummy smile. It is seen when more than one of these conditions appear. Levels of gingival margin. The gingival margin of the maxillary central incisor and canine should be at the same level, whereas the gingival margin of the lateral incisor should be slightly inferior to the marginal height of central incisor and canine. Presence of buccal corridors. Buccal corridor is the space between buccal surface of distalmost teeth seen on smiling, which is mostly premolar, and angle of the mouth. The buccal corridors can be measured from the mesial line angle of the maxillary first premolar to the inner portion of the angle of the mouth. The buccal corridors should not be excessive or absent. Lack of buccal corridors can give rise to denture-like smile. And the fifth component in assessment of smile is the smile arc. Smile arc is defined as the relationship of the curvature of the incisal edges of maxillary incisors and canines to the curvature of lower lip. The smile arc may be convex, which is curved, straight, and reversed, which is inverted. In an ideal smile, the incisal edges of the maxillary anteriors are parallel to the curvature of the lower lips. Let's move on to examination of nose. Nose contributes to the aesthetic appearance of the face and dominates the midface. Here, we need to look for nasolabial angle. It is the angle formed between the lower border of the nose and a line connecting the intersection of nose and upper lip. Normal value of nasolabial angle is 110 degree. It decreases in patient with proclined maxillary anteriors or prognathic maxilla. It becomes acute, and it increases in patients with retroclined maxillary anteriors or retrognathic maxilla, where it becomes even more obtuse. Moving on to the examination of lips. Normally, the upper lip covers the entire labial surface of maxillary anteriors except the incisal edge of 2 to 3 mm. The lower lip covers the entire labial surface of the mandibular anteriors and 2 to 3 mm of incisal edge of the upper anteriors. Under this topic, we need to assess lip competency, lip tonicity, and lip step. Lip competency is nothing but the ability of the lips to be able to approximate without any strain. Right? So based on competency, lips can be classified as competent lips, incompetent lips, potentially incompetent lips, and everted lips. We say the lips are competent when the lips are in slight contact when the muscles are relaxed. They are seen in class 1 type of malocclusion cases. Lips is incompetent when they are morphologically short and they do not form a lip seal in a relaxed state. The lip seal can be achieved by active contraction of the perioral muscle and mentalis muscle. They are seen in open bite cases. We say the lips are potentially incompetent when they are normal lips but they fail to form a lip seal due to proclined upper incisors. They are seen in Dewey's class 1 type 2 malocclusion cases. We can also categorize lips as everted if they are hypertrophied with weak muscular tonicity. They are seen in class 2 division 1 malocclusion cases. Tonicity of lip is the amount of strain in the lips. The lips may be normotonic, hypertonic, or hypotonic in nature. We can't find any strain in normotonic lips and they are competent to each other, which is seen in skeletal class 1 cases. Hypertonic lips have increased strain and is seen in skeletal class 2 cases, vertical growth and short upper lip, and so on. In such cases, the child will not be able to approximate the lip without strain. The increased strain in lower lip is seen as puckering of soft tissues of chin area and loss of mentolabial sulcus. Upper lip is seen flattened with the loss of philtrum details. In skeletal class 3 cases, it is opposite because there is mandibular prognathism, right? So the patient tries to approximate the lips by straining the lower lip and the chin tissues. So in these cases, the upper lip is found to be hypertonic. The next type is hypotonic lips. They are seen in patients with mouth breathing habit where the upper and lower lips become redundant and everted. Now let's see what is lip step. In normal patients, when viewed from side, the lower lip will be 1 to 2 mm ahead of the upper lip. This is called as positive lip step. In class 2 cases, the upper lip will be far ahead of lower lip and this is called as negative lip step. In class 3 cases, pronounced positive lip step is found where it is similar to type 1, which is positive lip step or normal lip step. But here there will be marked protrusion of lower lip. In this diagram, you could be able to appreciate that in positive lip step, the upper lip protrudes slightly over the lower lip. In the second diagram, there is marked retrusion of lower lip in relation to the upper lip. It is seen in class 2 malocclusion cases. In the third diagram, we could be able to appreciate the lower lip's protrusion in relation to upper lip. The lower lip is markedly protruded. So this is seen in class 3 malocclusion cases. Next, we have something known as lip trap. It is seen in severe class 2 division 1 cases where the incisors are proclined. In this case, the lower lip tucks behind the maxillary incisors at rest and prevents proper lip seal. It is called as lip trap. Let's move on to examination of chin. Chin is an important part of the face and has effect on facial profile and aesthetics. Firstly, we need to look for mentolabial sulcus. Mentolabial sulcus is the concavity present below the lower lip. Mentolabial sulcus can be normal, shallow or deep. It is normal in class 1 malocclusion cases. Mentolabial sulcus is shallow in bimaxillary protrusion and skeletal class 3 cases with mandibular prognathism. It is deep in class 2 division 2 malocclusion and abnormal mentalis activity. Also, we need to look for chin prominence. Prominent chin is seen in class 3 malocclusion and recessive chin is seen in class 2 division 1 malocclusion. Overdevelopment of chin height alters the lower lip position and interferes with lip closure also. And finally, we have mentalis activity. Configuration of the soft tissue of chin is not only determined by the bone structure but also by the thickness and tone of mentalis muscle. Normally, the mentalis muscle does not show any contraction at rest. Hyperactive mentalis activity is seen in some malocclusions such as class 2 division 1 cases which causes puckering of the chin. And that brings us to the end of the video. I hope you guys found it helpful. Do like this video and subscribe to Medinare for more. Thanks for watching.